What is going on, wonderful people? It's Medicosis Perfectionalis, where medicine makes perfect sense. Welcome back to my anatomy playlist. In this video, we shall talk about the pectoral region, which is here. What does the word pectoral even mean? It means chest. That's why the term angina pectoris literally means chest pain. Angina means pain and pectoris means chest. Angina pectoris, chest pain. In this video, you will learn about the surface anatomy of the pectoral region, the three main muscles of the pectoral region, which are number 1, pectoralis major muscle, number 2, pectoralis minor muscle, and number 3, the subclavius muscle, which is under the clavicle. We'll also talk about the nerve supply of the pectoral region and the arterial supply of the pectoral region. Now, please click the like button, click the subscribe button to help me get this burden off my chest. This is my anatomy playlist. Please watch all these videos in order. And if you do not have time, at least watch my anatomy review videos, which include review videos for neuroanatomy and embryology. Each branch of anatomy is covered in 3 separate videos. There is part 1, part 2, and part 3. Part 1 is the quick review, part 2 is ultimate review, and part 3 is clinically oriented anatomy. So I have a video on quick review of the thorax, another ultimate review of the thorax, and another clinically oriented anatomy of the thorax. And we repeat the same process for every subject in anatomy, including neuro and embryology. This is the anterior aspect of a human male with a gynecoid pelvis. To learn more about the different shapes of the pelvis, see my video on anatomy review of the pelvis. If you know anything about accountants and economists, you know that they hate one another. And if you know anything about anatomists or surgeons, you know that they cuss at each other and it gets nasty. And that's why the anatomical head of the humerus is different from the surgical head of the humerus. That's the dispute yet again between these two groups of people. Similarly, if I ask an anatomist, hey, what is the line of demarcation between the thorax and the abdomen? The anatomy professor will say, well, it's right after the rib cage. When the rib cage is gone, then the chest is over. So therefore, this is the line of demarcation between the chest above and the abdomen below. But the surgeon will reply to this and say, well, what the anatomy professor said is a load of bilge water. Because from a surgical perspective, the abdomen starts just at the level of the nipple. Why is this? Is the surgeon being ridiculous? No, to the contrary, the surgeon is being practical. And that's why we do not let anatomy professors anywhere near patients, because the patient will be losing liters and liters of blood. Meanwhile, the anatomy professor is enumerating the different origins of the latissimus dorsi muscle. Now, how is the surgeon being more practical here? Well, let's draw a person from a lateral view. All right, this is Adam. Okay, Adam. This is Adam's apple, Adam's chest, and Adam's abdomen. And this is Adam's nipple. If you know anything about the anatomy of the diaphragm, you know that it looks like a dome, and the dome is very high and steep like this. Which means it's very easy to imagine a gunshot wound or a bullet passing just below the nipple and then puncturing the spleen, the liver, etc. Which is abdomen, by the way. Oh, but it's just below the nipple. It's here. According to the anatomy professor, that's still part of the thorax. The same bullet can injure the thorax and the abdomen. So in other words, do not take your anatomy professor too seriously. And do not listen to your surgeon too much either, because the surgeon's solution to every problem is, you guessed it, do surgery. And just like you should not ask your barber whether or not you need a haircut, because the answer is always yes, of course, you shouldn't ask the surgeon whether or not you need surgery, because the answer will be, yeah, of course, unless the surgeon possesses honesty and integrity, which are becoming more rare by the second. How many pectoral regions do you have? The answer is 2. You only have the pectoral region anteriorly, not posteriorly. Next, I always start with my non-negotiables. Mistakes in the following points are not allowed. The following facts are so basic that the pH is beginning to rise. The first basic fact, or group of facts. This is your left ventricle, which has oxygenated blood. Of course, the oxygenated blood will be ejected from the left ventricle to this aorta. Starting by the left ventricular cavity, then the left ventricular outflow tract, and after this, you go to the aorta. There is the ascending aorta, the aortic arch, and the descending thoracic aorta. After the aorta pierces the diaphragm, or more accurately, disappears behind the diaphragm, it changes its name by a verbal sleight of hand from descending thoracic aorta to abdominal aorta. And then the abdominal aorta will end by dividing into right common iliac and left common iliac arteries. Each common iliac artery will give me external iliac and internal iliac arteries. This is true for the right side and the left side as well. Here's a question for the pros. At which vertebral level does the aorta pierce the diaphragm? If you know, comment below. What are the branches of the ascending aorta? The answer is the right coronary artery and the left coronary artery. Why do we call them coronary? Because they surround the heart like a crown. Isn't that beautiful? Of course it is. Until they get blocked. Then it's painful. Hashtag angina pectoris. If you wish to see more videos like this in the future, drop a heart emoji in the comments. But what are the branches of the aortic arch? The first one is the brachiocephalic trunk, followed by left common carotid artery, and then left subclavian artery. The brachiocephalic trunk takes care of your right side. Left common carotid and left subclavian will take care of your left side. Why do we have only one on the right but two on the left? That's a good question. But wait for it. Good things happen to those who wait. The brachiocephalic trunk will then divide into two arteries on the right to be equivalent to the two arteries on the left. So I have a right subclavian artery and a right common carotid artery. What's going to happen to the right subclavian artery? The right subclavian artery will become the right axillary artery, located in your smelly axilla. And then the right axillary artery will change its name again by a verbal sleight of hand to the brachial artery in your brachium, which means arm. And then the brachial artery will divide into radial artery and ulnar artery. The radial is always lateral towards your thumb, and the ulnar is always medial towards your pinky finger or your little finger. But how about the common carotid artery? The common carotid artery shall divide into the external carotid artery for your face and your internal carotid artery for your brain, especially the anterior circulation of your brain. But how about the posterior circulation of the brain? The posterior circulation of the brain is provided by a doozy, vertebral artery, which is a branch of the subclavian artery. And of course, you have a vertebral on the right and a vertebral on the left. So the subclavian artery will give me a famous branch upstairs. That's the vertebral artery going towards the brain. It also gives me a famous branch going downstairs. And this is the famous internal thoracic artery, otherwise known as the internal mammary artery. If it's called mammary, it means it comes close to your mammary glands. If you wish to download these doozy colorful notes, go to medicosisperfectionalis.com. I help you learn, understand, and pass exams. If you want me to personally tutor you, reach out to me on my website. Another basic fact, quote, if you lose money for the firm, I will be forgiving. But if you lose reputation, I will be ruthless, said the Oracle of Omaha. May I borrow his thoughts and say, dear student or dear doctor, if you forget about the arterial supply of the iliocostalis thoracis, I'll be forgiving. But if you injure your patient's intercostal neurovascular bundle, I will kick your gluteus maximus. Rhetorically speaking, I'll be so upset. I'll be so mad. Like an Italian grandmother after you break the spaghetti. Hey, signora, don't break the pasta. I'm so sorry. This is the rib, this is another rib. Let's say that this is the third rib and the fourth rib. Okay. Where is the intercostal space? Intercostal literally means between the ribs. So this is the intercostal space, the space between the ribs. Okay. In the intercostal space, we have the intercostal neurovascular bundle, which has intercostal nerve, intercostal artery, and intercostal vein. In order, they go like this. Van, from above downwards. V, then the A, then the N. The intercostal vein, then the artery, followed by the intercostal nerve. Please note that this nerve and these vessels occupy the lower aspect of the rib more so than the upper aspect of the other rib. They are more of below the rib rather than above it. Which means, if you have to puncture the pleural space, maybe because your patient has tension pneumothorax and you're trying to relieve the tension by performing a needle thoracostomy or needle decompression to relieve the tension or the pressure. Where should you stick the needle? Between the ribs, of course. But be specific. Should you go more of above the rib or below the other rib? The answer is above the rib, because above the rib is far away from the neurovascular bundle. But if you stick your needle below the rib like this, you might injure the nerve or worse, the artery. And that will be a doofus mistake that I will never forgive. Now please pause the video and try to label these structures. Now pause. This is the thoracic inlet. This is the thoracic outlet. And again, because anatomy professors and surgeons hate one another, when we say thoracic outlet syndrome, we mean the disease is here. I know it's weird. Get used to it. There are many things in medicine that just do not make sense. Like, why do you call it myasthenia gravis if it's not related to the gravid uterus? And why would you call it pulsus paradoxus when it's neither a pulse nor a paradox? And why would you call my lesion pyogenic granuloma when it's neither a granuloma nor does it have pus? I mean, stop it already. And if I develop cancer in my lymph node, why do you call it lymphoma rather than lymphosarcoma? It's malignant. And if I develop cancer in my liver, why do you call it hepatoma even though it's a carcinoma? Too many questions, too few answers. And if we are supposed to denote inflammation by adding the suffix itis to the name of the organ, so the inflammation of the sinuses is sinusitis, inflammation of the bronchi is bronchitis, inflammation of the hepatocytes is hepatitis, then if my pleura is inflamed, I should call it pleuritis, right? No, we're just gonna call it pleurisy. Oh snap. And then you have the audacity to wonder why your students are depressed. It's a real Scooby-Doo mystery. But I digress. C is the manubrium sterni, or the manubrium of the sternum. This is the body of the sternum. This is the xiphoid process. This is the manubriosternal junction, and this is the xiphisternal junction. The manubriosternal junction is also known as the sternal angle of Lewis. This is the suprasternal notch. The clavicles are going to articulate here, forming the sternoclavicular joints at this end, and the acromioclavicular joints when they articulate with the scapulae or the shoulder blades. D are the ribs, and they have costal cartilages as they hit the sternum. So choice E is the costal cartilage. Which rib is this? 1, 2, 3, 4. It's the fourth rib and the fourth costal cartilage. F is the 12th thoracic vertebra. And G is the intervertebral disc between the 10th and the 11th thoracic vertebra. Question: what type of cartilage is located in the intervertebral disc? If you know, comment below. So again, if you decide to stick your needle into the pleural space, go above the rib, not below the rib. Go here, not here. To make sure that you know all of this, please pause the video and label all of these structures again. Now pause. What is A? That's the skin, which contains epidermis, followed by dermis underneath. Then B is the hypodermis, otherwise known as the superficial fascia. The green line is the deep fascia, which does not have a letter. C is a famous muscle, which is the pectoralis major muscle, which is the topic of today's video. Then between this rib and the other rib, we have three muscles. Two in front of the neurovascular bundle and one behind the neurovascular bundle. What is E? The external intercostal muscle, otherwise known as intercostalis externa. How about letter F? Intercostalis interna, or internal intercostal muscle. Intercostal because it's between the ribs. External and internal. And what is G? Transversus thoracis muscle. You know what this reminds me of? It reminds me of what happens in the abdomen, the muscles of the anterior abdominal wall. We had external abdominal oblique, followed by internal abdominal oblique, followed by transversus abdominis, as opposed to transversus thoracis. Thoracis when I'm in the thorax, abdominis when I'm in the abdomen. No duh. And the neurovascular bundle again is intercostal vein, then intercostal artery, and below it, intercostal nerve. Then H is the parietal pleura. J is the visceral pleura. Between them, I is the pleural space or the pleural cavity filled with pleural fluid. Question: is this a serous fluid or a mucinous fluid? If you know, comment below. And K is the lung. These are the layers. You have to know them by heart in order to delight my chest. Pun intended. Please take a moment to pause the video and review them again. Practice active recall. Did you notice that the right main stem bronchus is more vertical compared to the left main stem bronchus, which is more horizontal? And that's why if you get infected with any respiratory virus or bacterium, they are more likely to infect your right lung compared to your left lung. Moreover, Aspiration or aspiration pneumonia or aspiration pneumonitis is more common on the right side rather than on the left side because physics. Next, surface anatomy of the thoracic wall or the chest wall or the anterior chest wall to be specific. Do you remember the sternal angle of Lewis, also known as the manubrio-sternal junction? Yeah, it's here. Above the manubrium of the sternum, we have the suprasternal notch, otherwise known as the jugular notch because it's in the neck near the jugulars. Beneath the sternum, of course, we have infrasternal notch. The muscle that lies underneath the breast is the pectoralis major muscle. This is the serratus anterior muscle. And if we call it serratus anterior, you can bet the rent money that there is another muscle named serratus posterior from behind. This is the rectus abdominis muscle. This is the linea alba or white line, which during pregnancy becomes linea nigra. It gets darker due to the hyperpigmentation of pregnancy. If you want to know why hyperpigmentation takes place during pregnancy, refer to my obstetrics and gynecology playlist. What's the name of this dorsi muscle that runs oblique? It's the sternocleidomastoid muscle. Why do you call it sterno? It's attached to the sternum. Why do you call it clado? It's attached to the clavicle, which is the collarbone. And why do you call it mastoid? Because it's attached to the mastoid process behind your ear. This is a lateral view, and this is the pectoral region, and this is the pectoralis muscle. Here's a question. Is this the left lung or the right lung? Comment below. Now, if you want to know about the 9 regions of the abdomen and the 4 quadrants of the abdomen, refer to my video on the abdomen. But today we're talking about the thorax. This is the anterior median line in the midline anteriorly. It's also known as the mid-sternal line because it runs in the middle of the sternum. This is the lateral sternal line, lateral to the sternum, or the lateral border of the sternum to be specific. This is the parasternal line, parallel to the sternum. And this is the mammary line, which runs by your mammary glands. By the way, don't forget that if you want to palpate or auscultate the apex of the heart, which is made by the left ventricle, you should put your finger or your stethoscope half an inch below the nipple. Of course, the position might vary in females due to the varying sizes of the breast. Next, the line that runs in the middle of the clavicle or the collarbone is called the mid-clavicular line. So this is the mid-clavicular line right here. Then we have the anterior axillary line, mid-axillary line, and posterior axillary line. And from behind, when you find the inferior angle of the scapula, you would have found the scapular line. What is this dude looking at? This is the anterior belly of the digastric muscle. If you know the name of the nerve that supplies the anterior belly of the digastric muscle, comment below. How about the nerve that supplies the posterior belly of the digastric muscle? Comment below. This is the mylohyoid muscle or mylohyoides. This is the hyoid bone. This is the thyroid cartilage or Adam's apple. And this is the cricoid cartilage. The continuation of the cricoid cartilage is, you guessed it, the trachea or the trachea. Again, this is the sternocleidomastoid muscle. This is the jugular notch or suprasternal notch. The sternocleidomastoid muscle has a sternal head and a clavicular head for the sternum and the clavicle respectively. And this triangle is made by the trapezius muscle. This is the clavicle. Amazing. Above it, there is the supraclavicular fossa. Below it, infraclavicular fossa. This is the clavicle. This is the sternal end of the sternocleidomastoid muscle, and this is the clavicular end of the sternocleidomastoid muscle. This is the pectoralis major, and this is serratus anterior. These anatomy illustrations are more than 500 years old, drawn by my faithful student, my boy Leonardo, the man who did not break the pasta. The most fascinating figure of the Renaissance was born on April 15th, 1452, near the village of Vinci, some 60 miles from Florence. Perhaps the scientist grew out of the artist. Leonardo's painting compelled him to study anatomy, the laws of proportion and perspective, the composition and reflection of light, the chemistry of pigments and oils. He almost inaugurated modern comparative anatomy by studying the limbs of men and animals in juxtaposition. He set aside the superannuated authority of Galen and worked with actual bodies. The anatomy of man he described not only in words, but in drawings that excelled anything yet done in the field. He planned a book on the subject and left it hundreds of illustrations and notes. Meanwhile, Medicosis has more than 2,700 videos with illustrations. So tell me, who is winning? Leonardo should have gotten his act packed together. He claimed to have dissected more than 30 human cadavers, and his countless drawings of the fetus, the heart, lungs, skeleton, musculature, viscera, eye, skull, and the brain, and the principal organs in women, support his claim. He was the first to give, in remarkable drawings and notes, a scientific representation of the uterus, and he described accurately the 3 membranes enclosing the fetus. This is a reference to the fetal membranes. If you have watched my embryology review videos, I've given you 5 examples of fetal membranes. Can you enumerate these fetal membranes? Let me know in the comments. So Leonardo described the uterus, but who described the fallopian tube? Another Italian gentleman, Gabriele Falloppio. He was the first to delineate the cavity of the bone that supports the cheek. I want you to pause the video and try to figure out what this is referring to. The answer is, this is a reference to the maxillary air sinuses, or the paranasal sinus in the maxilla. The maxillary sinus is the same as the maxillary antrum or the antrum of Highmore. He poured wax into the valves of the heart of a dead bull to get an exact impression of the chambers. Very clever. He was the first to characterize the moderator band, or the catena of the right ventricle. It's also known as the septomarginal trabecula, which is a muscular structure in the right ventricle, which conducts part of the right bundle branch. You can learn more by watching my video on anatomy of the thorax review, as well as my cardiology playlist. He was fascinated by the network of blood vessels. He divided the circulation of the blood, but did not quite grasp its mechanism. The heart, he wrote, is much stronger than other muscles. He traced the blood vessels, nerves, and muscles of the body with fair accuracy. He attributed old age to arteriosclerosis, facts, and this to lack of exercise. This is half facts, because he ignored the role of genes. But I forgive him, for he lived hundreds of years before Gregor Mendel, who in turn lived hundreds of years before Watson and Crick. He began a volume, De Figure Humana, on the proper proportions of the figures of man. As an aid to artists, he analyzed the physical life of man from birth to decay, and then planned a survey of mental life. Oh, that it may please God to let me also expound the psychology of habits of man, in such fashion as I'm describing his body. So here is a psychologist hundreds of years before Freud, Jung, and James. Probably he did little painting after 1517, for in that year he suffered a paralytic stroke that immobilized his right side. So most probably the stroke was in the left half of the brain. Usually, not always. He painted with his left hand, but needed both hands for careful work. So even after his right hand was paralyzed, he still drew with his left hand. That's just genius. Back to the pectoral region. Let's go above and beyond. What do you see here? The scalene muscle. We have scalenus anterior, scalenus medius, and scalenus posterior. Be very careful, because the roots of the brachial plexus, these nerves, run between scalenus anterior and scalenus medius, accompanied by the subclavian artery, but not vein. For the vein runs in front of the scalenus anterior, whereas the subclavian artery runs behind the scalenus anterior together with the roots of the brachial plexus. Now let's go below and underneath. This is the pectoralis major again. This is the external abdominal oblique, or obliquus externus abdominis. This is the serrated serratus anterior muscle. And this is the famous latissimus dorsi muscle. To say that this muscle is huge is to understate the fact. This is the linea alba again, and this is the umbilicus. What is the name of the dermatome, or the level of the dermatome that supplies the skin of the umbilicus? If you know, comment below. Is it T4, T6, T7, T10, T12, or L1, or what? Now, what if we dissect deep to this muscle? What would we see? You would see this, the internal abdominal oblique muscle, or obliquus internus abdominis. And after you remove the pectoralis major muscle, what would you see? The intercostal muscles, which are intercostalis externus, followed by intercostalis internus, followed by transversus thoracis muscle. External intercostal, then internal intercostal, and the deepest is intercostalis thoracis. Now, why don't we look from the inside? This is the sternum from the inside, so this is the back of the sternum. Here we have the lungs, but we're going to remove them. And what do you see? The deepest one is the transversus thoracis muscle. more superficial to it is the internal intercostal muscle. And then the most superficial is the external intercostal muscle. Please note that the direction of the muscle fibers are different between external intercostal, internal intercostal, and transversus thoracis. What if we decide to dissect the internal abdominal oblique and look behind it, or deeper to it? What would we see? We will see the transversus abdominis muscle. This is the rectus abdominis muscle and the rectus sheath. To learn about the inguinal rings, inguinal ligament, and inguinal canal, please refer to my review videos on anatomy of the abdomen. And in the back, we see a bunch of muscles that most students have no idea about. If you want me to make a video on the anatomy of the back, let me know. Now let's add more muscles superficial to these. And we see the famous trapezius, which looks like a trapezium or a rhombus. This is the big latissimus dorsi again. This is the spine of the scapula, above it supraspinatus, below it infraspinatus, and the triangle of your shoulder is the deltoid, because delta means a triangle. That's why the Greek letter delta looks like this. Do you remember the serratus anterior? Yeah. This is the serratus posterior. Now first we'll talk about the skin of the pectoral region, then we'll talk about the superficial fascia of the pectoral region, then the deep fascia of the pectoral region, then we'll talk about the three muscles of the pectoral region, which are pectoralis major, pectoralis minor, and subclavius muscle. Then we'll talk about nerve supply and blood supply of the pectoral region. So let's go. First, the skin. This is the skin of the pectoral region. What is the cutaneous nerve supply for that skin? Well, you need to find the sternal angle of Lewis. Okay, this is the sternal angle of Lewis, which is the manubriosternal angle or the manubriosternal junction. The skin above this manubriosternal junction or sternal angle is supplied by supraclavicular nerves, the root value of which is C3 and C4. How about the skin below the level of the sternal angle? It is supplied by lateral cutaneous branches and anterior cutaneous branches of intercostal nerves. And of course, these are thoracic rather than cervical. And by the way, these intercostal nerves run in this fashion so that every nerve supplies a thin slice of skin. This is very important, by the way, because you can have a patient with pneumonia who has abdominal pain from the pneumonia. Why would pneumonia, which is a disease in the chest, cause abdominal pain? Because the intercostal nerves run oblique in some areas. So I can start with the pneumonia, which is going to irritate the pleura, and the pleura irritates the intercostal nerve, and the pain is going to be referred to the abdomen. Third, how about the skin of the floor of the axilla? It is supplied by the second intercostal nerve, which is a branch of T2. Can you pause the video and label all of these structures? Now pause. A is the skin, which contains epidermis and dermis. B is the superficial fascia or the hypodermis. C is the pectoralis major muscle. D is the clavicle. E is the subclavius muscle under the clavicle. How about F? Pectoralis minor, deep to the pectoralis major muscle. We're done with the skin. Underneath the skin, we find the hypodermis, also known as the superficial fascia, which contains the platysma muscle. Here is a muscle within the fascia, or a muscle within the fat, and the human breast. The mammary glands are part of the superficial fascia, which means that the human breast lies in front of, or anterior to, or on top of the pectoralis major muscle. And if you have watched my physiology playlist, I've taught you that there are 4 hormones that act on the breast. Estrogen adds fat to the breast, which now makes perfect sense once you understand that the breast is part of the superficial fascia of the pectoral region. It makes perfect sense. Estrogen also grows the nipple and the ducts, but not the acini, for the acini are the function of progesterone. You can call these acini or lobules or alveoli. Then prolactin is gonna fill those acini with milk. So prolactin is for milk production. It is prolactation. And then oxytocin is gonna push the milk out. The same oxytocin also contracts the uterus and can push the baby out. This oxytocin can be released in excess by massaging the nipple. So when the baby latches onto the nipple, the mother makes more oxytocin, which is going to push the milk out. The same oxytocin that affects the breast is the same oxytocin that contracts the uterus. And that's why, in some cases of obstructed labor or labor dystocia, when the baby doesn't want to come out, one way to help with this obstructed labor is to massage the breast, because it releases oxytocin, which contracts the uterus, which pushes the baby out. This is written in textbooks. This is true, but this is rarely done in reality, for obvious reasons, of course. We're done with the superficial fascia, then we have the deep fascia. This pectoral fascia is a deep fascia which is going to encircle and ensheath the pectoralis major muscle. So here are the three muscles of the pectoral region. We have the pectoralis major muscle, pectoralis minor muscle, and subclavius muscle. Now let's talk about these three muscles. By the way, all of them are supplied by the brachial plexus, and as you know, the brachial plexus runs from C5 all the way until T1. If you haven't watched my video on the brachial plexus, I have no idea what you're doing with your life. Again, this is pectoralis major, this is pectoralis minor, and this is subclavius. In order to understand the brachial plexus, everything has to be number 5. So we have 5 things. We have roots, we have trunks, we have divisions, we have cords, and we have branches. How many roots do we have? The answer is 5. C5, C6, C7, C8, and T1. How many terminal branches do we have? The answer is 5. Musculocutaneous nerve, median nerve, ulnar nerve, axillary nerve, and radial nerve. You see this one right here? This is called the lateral cord of the brachial plexus, which is going to give us the lateral pectoral nerve, which is going to supply the pectoralis major muscle, but not the minor. Next, do you see this? This is the medial cord of the brachial plexus, which is going to give me the medial pectoral nerve, which will supply both pectoralis major and pectoralis minor muscles. Do you see this? I don't see it. This is the upper trunk of the brachial plexus. It's gonna give us something supra and something sub, something above and something below, supra and sub, suprascapular nerve and nerve to subclavius. And this is the nerve that supplies the subclavius muscle. So the pectoralis major muscle is supplied by lateral pectoral nerve and medial pectoral nerve. The pectoralis minor muscle is supplied by the medial pectoral nerve. And the subclavius muscle is supplied by nerve to subclavius. This is the lateral pectoral nerve, formerly known as lateral anterior thoracic nerve. As you see, it supplies the lateral part of the anterior chest, i.e. the lateral portion of the pectoral region. And this is the medial pectoral nerve, formerly known as medial anterior thoracic nerve. And did you know that the lateral and the medial pectoral nerves join one another? Again, pectoralis major muscle supplied by medial and lateral pectoral nerves. This is the pectoralis minor muscle supplied by the medial pectoral nerve, and this is subclavius muscle supplied by nerve to subclavius, which is a branch of the upper trunk of the brachial plexus. Let's start with pectoralis major muscle. It's a huge muscle, as you see. It has a clavicular head and it has a sternocostal head. The clavicular head takes its origin from the clavicle, whereas the sternocostal head takes origin from the sternum and the ribs or costal cartilages. Let's be more specific. From which part of the clavicle, please? From the medial half of the anterior surface of the clavicle. And from which part of the sternum, please? From the anterior surface of the sternum. And from which costal cartilages, please? The answer is the upper 6 costal cartilages. That's amazing. How about the insertion of the pectoralis major muscle? It inserts into the humerus. Be specific. Into the bicipital groove of the biceps brachii of the humerus. Which lip of the groove? Is it the medial lip? No, it's the lateral lip. Nerve supply, medial and lateral pectoral nerves. The medial pectoral nerve is a branch of the medial cord of brachial plexus, and the lateral pectoral nerve is a branch of the lateral cord of brachial plexus. How about the action of the pectoralis major muscle? Flexion of the arm, adduction of the arm, and medial rotation of the arm. Be careful, in anatomy, this is the arm, and this is the forearm. Next, the pectoralis major can elevate the ribs during forced or deep inspiration, not during quiet inspiration. So what are the muscles of normal quiet inspiration? The answer is the diaphragm and the external intercostal muscles. How about the muscles of deep or forced inspiration? These are pectoralis major muscle, sternocleidomastoid muscle, serratus anterior muscle, and even the scalene muscles of the neck can pull the ribs from above. Next, pectoralis minor muscle. Origin and then insertion. Origin. The pectoralis minor muscle is tiny. It takes origin from the third rib, the fourth rib, and the fifth rib. Rib, not costal cartilage. Pectoralis major took origin from the first 6 costal cartilages, not ribs, but minor originates from 3, 4, and 5 ribs, not costal cartilages. Insertion of the pectoralis minor muscle, not into the humerus, but rather into the scapula, into the coracoid process of the scapula. Please do not confuse coracoid with coronoid. They are not the same. Coracoid is in the scapula. Coronoid is in another bone. Where is the coronoid located? If you know the answer, comment below. And by the way, there is a difference between coronoid process and coronoid fossa. They are located in different bones. Let me know in the comments. How about innervation of pectoralis minor? Pectoralis minor is supplied by the medial pectoral nerve, which is a branch of the medial cord of the brachial plexus. How about the action of the pectoralis minor? To understand the action, bring the origin closer to the insertion. And as you go this way, you're gonna pull the ribs outwards and upwards, which is gonna help with deep inspiration, as we have discussed. Acting from below, we can depress the scapula, and we can also protrude the scapula forwards because of how your thoracic cavity is shaped. The third and final muscle of the pectoral region is subclavius. Where is subclavius? Under the clavicle. Subclavius, under the clavicle. Origin, first rib and costal cartilage. Insertion into the middle 1/3 of the clavicle. Innervation by nerve to subclavius, which is a branch of the upper trunk of the brachial plexus. Root value C5 and C6, because that's the root value of the upper trunk of the brachial plexus. Action. By bringing the insertion closer to the origin, we can steady the clavicle at the sternoclavicular joint to make sure that the clavicle remains stable and steady. Also, the subclavius muscle acts as a pad of protection, protecting the axillary nerve and the axillary vessels as they pass into your smelly axilla. Again, lateral pectoral nerve for the pectoralis major, medial pectoral nerve for both pectoralis major and pectoralis minor, and the nerve to subclavius for the subclavius. Next, arterial supply of the pectoral region. Branch of the axillary artery, branch of the internal mammary or internal thoracic artery, and branch of the intercostal arteries. Which branch of the axillary artery? Superior thoracic artery, acromiothoracic artery, and lateral thoracic artery. By the way, the acromiothoracic is also known as thoracoacromial artery. Next, for the pros, where did the axillary artery come from? The axillary artery is a continuation of the subclavian artery. And where did the subclavian artery come from? Well, it depends. On the right side, it came from the brachiocephalic trunk, and on the left side, the left subclavian is a direct branch of the aortic arch. Next, where does the internal thoracic artery or the internal mammary artery come from? It comes from the subclavian artery, this guy. And where did the intercostal arteries come from? To learn about that, watch my video on anatomy of the thorax review. Cause to say that the origins of the intercostal arteries are complicated is the understatement of the century. This video will teach you about the intercostal arteries, intercostal veins, azygous vein, and hemiazygous veins. Please take a moment to pause and review and name all of these structures, and do this again with these structures. Don't forget to watch my anatomy review videos in my anatomy playlist, and there is another playlist on my channel called In 90 Minutes Quick Review, which has review videos for anatomy, embryology, physiology, biochemistry, cardiology in 90 minutes, endocrinology in 90 minutes, hematology in 90 minutes, and much more. If you want to learn about cardiothoracic surgery, vascular surgery, neurosurgery, trauma surgery, general surgery, and more, download my surgery high yields course at medicosisperfectionalis.com. If you value what I do, help me make more videos by supporting the channel. Go to buymeacoffee.com/medicosis. There are more than 750 premium videos available on this channel. When you click the join button and choose the highest tier. Please subscribe, hit the bell, smash like, support my channel on Patreon or PayPal or Venmo. Go to my website to download my courses, notes, and cases, or if you would like me to personally tutor you. Be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine, chemistry, math, and physics make perfect sense.